The day of reaching the destination. Just obeying an inner decision. Embarking on the journey. A precise, comprehensive, and people-benefiting solution for in vitro diagnostics serving the public health. Every inch gleams, condenses into the pulsating ideal. With a determined heart, courage emerges from past steps. Knowledge in motion, only focused on steadfast progress. The compact immune quantification analyzer initiates the self-developed era of Zybio. The eruption of creativity. A rigorous competition with details. A mad breakthrough to the limits. Here we conquer several core technologies. Gene engineering antigens, antibodies, diagnostic nanomaterials, various signal amplifications, rapid nucleic acid extraction and PCR tests. Here, we collide sparks of wisdom, turning each conception into reality, launching a fully independent intellectual property TLA, and automated sample processing system EXLab. Here, we break free from fixed thinking, analyzing the concrete, perceiving innovation, understanding usage habits, anticipating customer needs. Cold modes convey delicate care. Lean management in every product detail. Light is not just a bright beam. It is the carrier of energy. Comprehensive is not merely all-encompassing. It empowers precision. The 9+1 product line, encompassing clinical chemistry, clear, POCT, coagulation, hematology, urinalysis, mass spectrometry, molecular, pathology, paired with intelligent laboratory management system, efficiently providing laboratory solutions worldwide. Research centers scattered across the country, connecting Zybio's intelligent network, breaking the technical barriers set by the industry, pulling together the entire industrial chain from raw materials to core components. Establishing the Zybio Technology Park, creating an integrated space for raw material development, research and design, and product manufacturing. Customer service covers full-time, online and offline. We integrate our thorough philosophy into every corner, fundamentally providing integrated, traceable products and thoughtful services. Dedication to accuracy. In the future, belonging to every sincere practitioner, interpreting the endless charm of the in vitro diagnostic industry with innovation, serving the public health with high-quality diagnostic solutions, promoting economic development and technological advancement in the industry. Light, carrying ideals, gathering energy. We, chasing the light, will ultimately become the light.
Ladies and gentlemen, we are truly delighted to welcome you to the fourth session of the DiagHub series, a global platform where professionals from all over the world come together to share knowledge, exchange ideas, and move diagnostic science forward. After 3 insightful sessions on clinical chemistry, POCT, and immunology, DiagHub has really grown into something special. A space for collaboration, for practical learning, and for keeping up with the real-world progress happening in lab medicine. Whether you are joining us today from Asia Pacific, Africa, Latin America, Europe, or anywhere else, Your continued presence and engagement are what make this series meaningful and impactful. So thank you for being here. Today, we are turning our focus to urinalysis, a field that may seem basic, but is in fact evolving rapidly and playing an increasing vital role in diagnostics. From early disease detection to patient monitoring, and now with advancements like automation, digital microscopy, and biomarker research, urinalysis is entering an exciting new era. We are honored to be joined by international experts who will share their latest findings and clinical insights. And we hope this session sparks some new thinking for your own work as well. So with that, let's get started. Welcome again, and thank you for being part of DiagHub. It is an honor to first introduce our distinguished moderator for today's session. We are pleased to welcome Dr. Sulakshmi Gulat-Ahi, a consultant pathologist at Jinnah Hospital Laboratory in India. She holds an MD in pathology from DY Patil Medical College, Pimpri, with over a decade experience in the field of pathology. Dr. Gulat-Ahi specializes in hematology, cytology, and clinical pathology. She currently oversees the hematology and clinical pathology sections of the laboratory and is actively involved in cytology reporting. We are honored to have her with us today. Please join me in welcoming her. Welcome, Dr. Sulakshmi Gulat-Ahi.
Thank you for the gracious introduction, Sinaya Wong. It is both a privilege and a pleasure to join this academic conference at the kind invitation of Zybio and to serve as your session host today. I am deeply honored to collaborate with distinguished experts from Indonesia and China on the DiagHub platform as we exchange cutting-edge insights in urine analysis today. Next, I will introduce the expert who will deliver the lecture first, Professor Dr. Ida Parvati. She holds a PhD from Radboud University Medical Center, Netherlands. She is the chair of the Indonesian College of Clinical Pathology. She is a professor of clinical pathology at Universitas Padjadjaran, head of the Advanced Biomedical Laboratory, Faculty of Medicine, Universitas Padjadjaran. She has over 30 years of experience in clinical pathology, education and leadership, published extensively on tuberculosis, diagnostics, urine biomarkers, leprosy, and molecular techniques in international journals. Please join me in welcoming Professor Dr. Ida Parvati for her lecture.
Thank you, Dr. Sulakshmi. Let me share my presentation. Okay, are you already seen my presentation?
Yes.
Okay, thank you. Okay, first of all, I would like to thanks to Zybio for the invitation to present about urinalysis as a screening tools for urinary tract infection and more. Yeah, this is the subtopics of my presentation, the journey of classification of UTI, new classification, diagnosis hallmark of UTI, pathophysiology, urinalysis, accuracy of urinalysis in UTI diagnosis, the role of urinalysis in UTI management, and the last is the take-home messages. If we see this picture, this is figure out and capture the evolving landscape of urinary tract infection classification over more than 3 decades, showcasing a shift from broad categories into clinically nuanced framework. We begin at the 1992. The IDSA, Infectious Disease Society of America, and European Society of Clinical Microbiology and Infectious Disease, they make a classification of UTI in very simply classification, uncomplicated or complicated infection. But this binary scheme is not lack of precision in addressing the diverse of patient presentation. So in 2016, the European Urology make a new classification consists of asymptomatic bacteriuria, acute uncomplicated UTI in women, uncomplicated cystitis in women, acute uncomplicated pyelonephritis, complicated UTI, and recurrent UTI. And this classification is not yet make everybody happy. So one researcher at Fanny and Friend make a new classification like continuum of urinary tract infection, but it is only 1 year after the European Association of Urology make a classification in 2025 this year based on clinical sign and symptoms. It's only two classification: localized UTI and systemic UTI. From this, we acknowledge that uh, the classification it should um, comprehensively in the end for the clinical management of UTI itself. Yeah, the progressive refinement of this classification demonstrate how classification is evolving, not just for academic clarity, but also for accurate diagnosis, tailored treatment, and better outcome in clinical practice. But I think the researcher and also the practitioner maybe is already happy with this classification, with the former classification like symptomatic with an asymptomatic and then symptomatic divided into two, complicated and uncomplicated. The complicated divided into two, acute complicated cystitis and pyelonephritis, and for complicated is to acute complicated cystitis, catheter associated UTI, and complicated nephritis. Let us have a closer look to improve classification of urinary tract infection. This classification is combine the clinical feature and the laboratory investigation. Here we can see that asymptomatic bacteria, no urinary symptoms, but the criteria of laboratory investigation should we find should more 10 white blood cell per ml and more 10 to the 5 CFU in two consecutive midstream urine culture. And for acute complicated UTI in women and cystitis in women, all the clinical feature is there. And also we have a category for laboratory finding. We have to have more than 10 white blood cell per ml and more than 10 to the 3 CFU in culture, colony in culture. Yeah, for uncomplicated, there is clinical feature like fever and etc. And the laboratory findings should have more than 10 white blood cell per ml and more than 10 to the 4 CFU. Complicated is any combination of symptoms above, yeah, with more advanced laboratory investigation findings, like more than 10 white blood cell per ml, more than 10 to the 5 CFU in women, and more than 10 to the 4 CFU in men or in straight catheter urine in women. The 5 category recurrent UTI, this is at least 3 episodes of uncomplicated infection documented by culture in the past 12 months. Women only, no structural and functional abnormalities. And in this category, the laboratory finding less than 10 to the third CFU is already make this classification. This is the latest classification from European Association of Urology. and divided into two categories: localized UTI and systemic UTI. Although this is clinical base, this is very important for the clinician. Uh, uh, but in clinical practice, the laboratory investigation should embedded in this category. This is the risk factor for UTI because not all people experience with this disease. Yeah, there is a UTI in the Oranoc systems and risk factor for urinary infection in general in B. The Urinox O is means no known risk factor. R risk factor is there. For E and U, there is involvement in extra urogenital, nephropathic, and urologic risk factor. And the C is catheterized. Regarding to the complexity of the Oranoc systems, the European Association of Urology stay in this general risk factor involving age and gender. We can see here that in infant, in geriatric or frail patient, yeah, and in male and female sex. This is the risk factor for UTI. This slide complemented to the previous classification, but in this slide, they call it the Fernandez is call it this is a diagnostic hallmark of UTI involving the presentation, the physical examination of the urine, the chemical, and the microscopic. We can see here that in the lower UTI and the upper UTI, the symptom is like what you see in the slide. When we see the laboratory finding, the physical and the chemical is just the same. Only in the microscopic, a little bit different. And then this is the pathophysiology. Because mostly the infection out of the urinary tract infection is come ascendingly, so it starts from the contamination of the periurethral area with the uropathogenic from the gut. We can see that uropathogen is in the left side, the UPEC, the uropathogen Escherichia coli. It's maybe 90% of the uropathogens is because of E. coli, and then the other the other bacteria like Klebsiella pneumoniae, Streptococcus saprophyticus, Enterococcus, group B Streptococcus, Proteus mirabilis, Pseudomonas aeruginosa, Streptococcus aureus, and Candida. They all what in every epidemiological finding of in UTI as a causative agent of UTI, but 90% it's because of the UPEC, E. coli. So from there will be a colonization in the urethra and migration to the bladder, and then colonization and the invasion of the bladder mediated by pili and adesin. And the other hand, the host also have an inflammatory response in the bladder and fibrinogen and accumulation in the catheter if there's come from catheter. And then there will be a neutrophil infiltration, bacterial multiplication, and immune system subversion, biofilm formation, epithelial damage by bacterial toxin and protease, and then ascension to the kidney. From until this section, maybe this is the UTI, but this the lower UTI, and this one is upper UTI, which involves the colonization in the kidney, host tissue damage by bacterial toxin, and bacteremia. So, what the relation of pathophysiology with urinalysis finding? So the release of bineutrophil during inflammation, it's indicate pyuria. We can find the leukocyte esterase positive. And nitrate positive is formed when nitrate reducing bacteria like E. coli metabolize urinary nitrates. Bacteriuria, of course, this is the direct presence of bacteria due to colonization and ascension from urethra to bladder. And hematuria, it's because epithelial disruption from inflammation or bacterial toxin leads to RBC leakage. And proteinuria, it is because increased permeability of inflamed urothelium allows protein leakage into urine. And white blood cell counts, it form in renal tubules during upper tract infection. For instance, pyelonephritis. And cloudy urine is because accumulation of white blood cell, bacteria, and epithelial debris. And we come across to the urinalysis itself. In this urinalysis, there will be a physical examination like color, specific gravity, turbidity, conductivity, osmolality, and chemistry examination. Report parameter, a lot of parameter we will explain in the next slide. And morphology examination like cell, cast, crystal, and microorganism. From moreover from Zybio urinalysis solution, they have a comprehensive chemistry parameters. In the upper part, like urobilinogen, bilirubin, ketone, until pH, it's a common from any urinalysis platform. But the interesting one in this Zybio, they have a microalbumin, creatinine, and calcium, and microalbumin creatinine ratio and protein creatinine ratio. This is very important for the clinical practice because it shows a kidney function. And the interpretation of those parameter for kidney function, it's come from CKD guideline and NDDC USAR reference that microalbumin, if less than 20 milligram per liter, is normal. Trace between 20 to 30 milligram per liter, and between +1, 30 to 100 milligram per liter. Microalbuminuria is early. This is an early kidney damage, and 100 to 30 milligram per liter, it is still early kidney damage. But if more than 300 milligram per liter, it's macroalbuminuria. It's overt proteinuria. For us, ACR or albumin to creatinine ratio, the range is, if it is less than 3, normal, 3 to 30, moderately increased macroalbuminuria, and more than 30, severely increased clinical proteinuria. The protein creatinine ratio range is less than 15, it's normal, 20 to 50 borderline, more than 50 significant proteinuria, and more than 100 nephrotic range proteinuria. The urinalysis morphology, this is also interesting in Zybio because if we compare to flow cytometry to digital images, the Zybio have a laminar flow imaging, but this part will be discussed by the next speaker, I think. This one I would like to point out of the accuracy of the urinalysis in common in one big research from China, if I am not mistaken. Here we can see that the population or the subject is nearly it's more than 4,000, and we can see here that urinalysis mostly leukocyte esterase have a very nice atau very high sensitivity and specificity compared to nitrate and pyuria. This is stratified by bacteremia status. Even in the without bacteremia, still leukocyte esterase is have a very high sensitivity and specificity. Compared to other study, this is from Indonesia in 2016. The the in this sorry in this is the from 2018. This is from 2016. We can see the still that leukocyte esterase is the highest, have a higher sensitivity, but in this study they have a low specificity. In the most recent study by Matu, we can see here that leukocyte esterase still have a high sensitivity and specificity, and nitrate because most of the time the causative agent is E. coli, they have a specificity very high. This is the characteristic of aggregate urinalysis diagnosing UTI certified by bacteremia status and age. We can see here that still the sensitivity, specificity of urinalysis, it's very high. Yeah. Although the positive predictive value is only 0.43, but the negative predictive value is 1. Yeah, it means also the likelihood ratio is 10 and likelihood ratio negative is 0.06. It means that the positive result of urinalysis, it's can be used as a ruling out of UTI. So how urinalysis help in UTI diagnosis? Yeah, it detects inflammatory marker, identifies bacterial activity, and assess urine characteristic. The leukocyte esterase, we already discussed it. Yeah, it's enzyme released by white blood cell. A positive LA test suggests pyuria indicating inflammation or infection. The microscopic white blood cell, this is we can see the real, a real white blood cell in the microscopic. It's confirmed the presence of inflammation or infection. Typically, more than 5 white blood cell per high powerful is considered abnormal. And then identifies bacterial activity, but by testing the nitrates, the certain bacteria, E. coli, yeah, convert urine nitrate to nitrates, positive nitrate, gram-negative bacteria. But not all uripathogen produce nitrates. A negative result doesn't rule out of infection. That's why the sensitivity of nitrates is lower than leukocyte esterase. Microscopic bacteria support the diagnosis when combined with pyuria. And assess urine characteristic. pH, normal urine is slightly acidic. Alkaline urine may indicate infection with urea splitting organism like Proteus species. And specific gravity help assess urine concentration and the appearance, like what I said before. Cloudy or turbid urine may suggest pyuria or bacteriuria. The urinalysis is also dynamic, like a classification of UTI itself. There are a lot of research about development of new technology and new biomarker, because although still a powerful screening test, urinalysis, a powerful screening test for UTI, but they also have a limitation. So there are a lot of research, like here we can see that a new biomarker like gelatinous associated lipocalin and GAL and PCT and maybe other more can be used as a new biomarker in the future. Not only the new biomarker, but also the development of technology like bacteriuria screen assay, rapid molecular identification from urine, next generation sequencing, and rapid phenotypic susceptibility test is also being developed right now. So what is the role of urinalysis in UTI management? Support decision making like screening tools. It's rapid, inexpensive, and effective, non-invasive. This is the most likely being preferred by the patient and ideal for initial evaluation or early diagnosis and management and prevent complication. Guides empirical treatment. This is also important because positive LA and nitrate in symptomatic patient often justify to start antibiotic while awaiting for culture result. And of course, this situation is support antibiotic stewardship and monitor treatment response. Of course, if we find a good result from monitor patient and the first time and the second urinalysis, it can be as a monitor for treatment response. But yeah, there still have a limitation like false positive because in the area of specimen collection, maybe we can have a contamination for vaginal secretion if the collection of specimen is improper. False negative because of low bacterial load or non-nitrate reducing organism or the dilute urine. So the result of urinalysis should be interpreted in clinical context, cannot identify specific pathogen or antibiotic resistant. So it requires culture confirmation. Moreover, in symptomatic and high-risk cases. And we have to have a special consideration in elderly because in elderly, asymptomatic bacteria is common, but no need antibiotic for that. So we have to interpret with caution and catheterize patient because pyuria is not uh, uh, 100% show because of infection. Again, in a clinical context matters. This is an example of algorithm to diagnose asymptomatic bacteria and UTI. This is from adult practical approach, diagnosis and management. Always start from the anamnesis. Does the patient have a clinical sign or symptomatic urea, localizing urea or systemic? If yes, go to urinalysis with reflex to culture if pyuria is present. And then, does the patient have pyuria? If yes, does the patient need empiric antibiotic therapy? Patient has localizing urinary or clinically unstable like fever and everything. If yes, it's probable or definite UTI. Give empiric antibiotic. From here, if no, so no UTI. If the patient don't have pyuria, no UTI. If have pyuria, but the if patient have localizing or clinically unstable symptoms, if no, maybe possible UTI, close monitoring for antibiotic. Yeah, this algorithm is important in clinical practice because in the if no UTI or is asymptomatic bacteria, no need antibiotic. This is from Nature Review overview the clinical workflow of existing and future diagnostic technology for UTI. Current practice and new technologies. We can see here in the first 1 to 2 hour bacteriuria screening by dipstick or microscopic. From there, we can also give empirical broad spectrum antibiotic. And then between 24-hour pathogen identification by chromogenic agar or automated biochemical or Malitov, we can have a conclusion that pathogen-specific antibiotic based on an antibiogram. So definite, this is empirical and this is definite antibiogram. And 48 hours more, we can see the result of IST, antimicrobial susceptibility testing. From there, we can give the patient the precision medicine. Individually tailored antibiotic therapy, improve antimicrobial stewardship. If we use the new technologies like point of care near patient testing, bilateral flow immunoassay screening, rapid optical screening, yeah, like integrated multiplex PCR and everything, we have a comprehensive testing, and this is also give us an opportunity to give the patient precision medicine. So the take-home messages from my presentation is urinalysis is a powerful tools for UTI screening, quick and accessible, non-invasive, cost-effective, high sensitivity, especially for leukocyte esterase and nitrates. Useful for triage and guiding further testing. And urinalysis guide empirical treatment while awaiting for culture result as a gold standard. This support antibiotic stewardship, and the negative result of urinalysis is useful for ruling out UTI, but urinalysis must be interpreted in clinical context. And the most important thing is proper urine specimen collection is a priority. From here, there is still a room for overwhelming the limitation of urinalysis in UTI screening by developing a new technology and incorporate new biomarker in urinalysis. So thank you for your attention. I think I finished my presentation. Thank you very much. I'll give
Okay.
back
We as a physician undervalue.
Dr. Sulaksmi. Yeah. Thank you.
Thank you. We as a physician undervalue the topic of urine analysis, although now understanding through Professor Dr. Ida, it's an extensive yet subject of concern. Thanks for the inspiring presentation. We are privileged to welcome Ms. Xijing Yong from China. Allow me to introduce our speaker. She's a product specialist at Diagnostics and Background. Reviewed journals. She has experience in and commercialization of bioactive proteins and reagents. She will now share her expertise on clinical application of image recognition in urine analysis. Let's give her a warm welcome.
Thank you, Doctor. Thank you for your introduction. And now let me share my screen. I hope you can all see my slides on your screens. So good morning, good afternoon, and good evening, experts and teachers. I'm Si Jingxiang, and I'm very honored to give a speech on DiagHub for urine analysis product line. We will focus on CAS detection, an important indicator for the diagnosis of kidney disease, especially when encountering mucus-positive samples. The core content is to show how Zybio's U3600 fully automated urine analysis system can significantly improve the accuracy and efficiency of CAS detection in such complex samples through its unique technological breakthroughs. So my presentation will be divided into 5 parts. First, we will quickly review the diverse formed elements in urine and their clinical significance. Secondly, let's delve into the casts themselves, and then we will face the core challenge of current cast detection, that is, the serious interference of mucus-positive samples in the accurate identification of casts. Next, I will introduce in detail the innovative technological advantages of the Zybio U3600 urinalysis system, especially how it breaks through the bottleneck of cast detection in mucus-positive samples. And fifth, we will summarize how Zybio's fully automated urine analysis solution systematically solves the difficulties faced by the clinical laboratories in urine testing. Let's get started with part 1. Analysis of urine-formed elements is an indispensable part of diagnosing urinary system diseases. These components, including the blood cells, red blood cells, white blood cells, epithelial cells, casts, crystals, bacteria, etc. Their appearance, quantity, and type in urine directly reflect the physiological or pathological state of the kidneys and urine tract. For example, observing RBC morphology can help determine whether the source of hematuria is glomerular or non-glomerular. White blood cells, for another example, especially those that form clumps of pus cells, are a strong sign of urinary tract infection. And crystals such as calcium oxalate crystals may be associated with metabolic abnormalities or stone risks in kidneys. And accurately identifying and classifying these shaped elements of various forms is the basis for clinicians to make correct diagnoses and decisions. However, the traditional reliance on inefficient and laborious manual microscopy is one of the pain points we're going to discuss today. Among many formed elements, casts have a special status. They are indicators of kidney diseases, especially tubular damage. Casts are essentially cylindrical. Casts formed by protein aggregation in the lumen of renal tubules, which wrap other components such as cells and particles flowing through here. In patients with long-term anuria or oliguria, casts stay in the kidneys for too long, and cell casts will gradually degrade and change to form coarse-grained casts, which can be further degraded to form fine-grained casts. Fine-grained casts would further homogenize and change into waxy casts. And among many formed elements, casts have a special status. They are indicators of kidney diseases, especially tubular damage. For example, red blood cells casts. This is the gold standard evidence for diagnosing active glomerulonephritis, such as acute post-streptococcal nephritis, lupus nephritis, indicating that red blood cells leak from the inflamed glomeruli and form casts in the renal tubules. Therefore, accurate detection and correct classification of casts are of decisive significance for the diagnosis of kidney disease. However, the detection of casts, especially those with relatively mild morphology, such as transparent casts or fine granular casts, faces a huge interference. Mucus threads. Mucus threads are common mucin fibers in urine. A small amount of mucus threads in urine is normal, and the normal value of mucus threads in urine routine is usually between 0 and 28 per microliter. It is easy to appear in large quantities when female reproductive tract secretions are mixed or there is inflammatory stimulation in the urinary system. The core problem is, under a microscope, mucus threads often appear as thin, curved, translucent threads or ribbons, like the one shown here on the right. A large number of mucus threads tend to entangle and aggregate, and their fluorescence intensity is consistent with transparent casts, so the instrument may mistakenly detect them as casts. The process from regular mucus threads 0 to helical mucus thread 1, shown here, and then to mucus thread 2 in this slide, just explains how mucus threads are transformed into casts step by step to confuse us. This cast is not formed in the renal tubules, so cast must not be reported. Otherwise, it is easy to reduce clinical considerations of kidney damages, causing unnecessary worries to patients. However, if we adopt manual microscopy, which is still the gold standard for urine-formed particles analysis, we are faced with the challenge that at a large number of urine specimens, manual microscopy is not only inefficient, but also easily affected by operating procedures and subjective factors resulting in errors, and it is difficult to meet the detection needs of large quantities of samples. Although some fully automated urine analysis systems can improve efficiency, the sensitivity and specificity are significantly reduced for some detection items, including CAS, especially under the interference of mucus threads. Here is an example from the real clinical world. In an evaluation study, which enrolled 1,000 samples from a tertiary hospital in China, 320 mucus-positive samples are analyzed to detect CAST with 3 different urine analyzers and manual microscopy in order to further explore the impact of mucus threads on CAST analysis. With manual microscopy as the standard, performances of U3600 and 2 other urine sediment analyzers in detecting CAS and mucus-positive samples were evaluated. From the results in Table 2, it can be seen that under the interference of mucus, compared with the other 2 devices, U3600 features the highest agreement with microscopy, and the sensitivity and specificity as well as the positive predictive value, PPV, for CAST samples are all high, showing good detection performance. The U3600 automated urine analysis system has optimized the algorithm, and the image segmentation and recognition are more accurate as well. In the mucus-positive samples, the detection of CAS shows 83% consistency with the gold standard manual microscopy. This technology has greatly facilitated clinical differentiation between CAS and mucus and reduced the misdiagnosis rate, related diseases, and high mucus cases. So how does Zybio U3600 solve this whole problem? In the face of these challenges, Zybio launched the revolutionary U3600 fully automated urine analysis machine. It is not just an instrument, but also an integrated solution. So first, true integration was equipped to this instrument. The 3 core functions of physical examination, dry chemical analysis, and formed element analysis are integrated into this one single platform. It is also an efficient and stable platform for automated urine analysis. The comprehensive measurement speed is up to 120 samples per hour, meeting the throughput requirements of large and medium-sized laboratories. Besides all of those mentioned above, it also has flexible response to emergency, truly achieving common tasks, buying precious time for critically ill patients. Comprehensive physical parameters are another very important factor for Zybio U3600 to make an impact. In addition to routine items, it provides in-depth physical indicators such as conductivity and osmolarity that can better reflect the concentration and dilution function of the kidney. So to understand how U3600, the system, solves the problem of CAS detection, we need to first understand the main technical roots and advantages and disadvantages of current urine-formed component analysis. So the first method here, flow cytometry, the core advantages are constant speed, high efficiency, and the ability to identify gram-negative / gram-positive bacteria through side fluorescence. However, the weakness is that it cannot provide a true image of the sample. The results are not visible, and the questionable samples must be reviewed by tedious manual microscopic examination. And for the second method presented here, the main advantage of the digital imaging method aka static segmentation photography, is that it can provide sample images. The results are traceable and the technical threshold is relatively low. However, its disadvantages are very prominent as well. It must go through time-consuming steps such as centrifugation and segmentation. And when photographing, usually only a very small area after segmentation is extracted for photography. And the number of images captured is small, and it is very easy to overlap and defocus. For the last but not least method presented here, which is exactly adopted by U3600, the laminar flow imaging method combines the advantages of the first two. It has both the constant speed and high efficiency of flow cytometry method, but it doesn't require centrifugation and segmentation. And the traceability of imaging method results provides real sample images. The core advantages include the several points. First, its constant speed and high efficiency. Second, it provides clear and searchable original images supporting automatic particle segmentation, greatly facilitating manual review. And the third advantage is that it doesn't require centrifugation and segmentation. So there's no need for you to use magnification lens conversion or repeated focusing or some other bottlenecks as that. Its relative disadvantage is that the cost of this method is slightly higher than the first two. And it is necessary to solve the problem of flow cell carryover contamination under high concentration samples, which is the focus of Zybio U3600's technological innovation. And for the following slides, I will explain the technological innovation of U3600 from three core dimensions. The first core technological breakthrough of our machine is that it upgraded laminar flow imaging technology. So how does it solve the pain points of such method? The core principle is that the sheath fluid wrapping and fluid focusing conducted during this whole process. The system uses precise sheath flow technology using the sheath fluid under the action of fluid mechanics to tightly wrap and compress the urine sample in the center. This forces the formed elements in the urine, such as cells, casts, and crystals, etc., to line up in a single roll and pass through a precisely defined imaging area, one by one at high speed, completely eliminating overlap and aggregation. In this way, each particle can be captured independently and clearly. So through this technology, our system automatically captures and stores the true morphological images of each sample and automatically segments and pre-classifies the particles. Inspectors can review the original pictures at any time, greatly reducing the reliance on tedious manual steps. The second core technology of this machine is that it utilizes intelligent medical image recognition technology. Having a clear image is the first step, and how to accurately understand the image is the key, especially in the challenging identification of casts in mucus-positive samples. So how to improve cast recognition, especially against such interference? Well, we use powerful AI algorithms to learn subtle but critical differences in morphological details such as texture, features, edge properties, optical densities of casts, and mucus filaments, which are often easily overlooked by the human eye during rapid microscopic examination. And continuous software upgrades are often conducted by our R&D department as well. This is not a static system. Zybio promises and provides continuous intelligent software upgrade services, pushing the latest algorithm optimizations and newly added recognition types to users to ensure that system performances keeps pace with the times and becomes stronger with use. And the third core technology of this machine is the innovative sheath flow cell structure design. It solves two key physical challenges faced by laminar flow technology in the past: imaging clarity and carryover contamination. So first, to ensure imaging clarity, U3600 adopts a newly upgraded symmetrical sheath flow cell design. The optimized fluid dynamics with its core role to ensure that the sample flow wrapped by the sheath fluid is more stable and centered, so that the single layer arranged particles can perfectly and continuously pass through the most accurate depth of field area of the ultra-high speed, high-definition camera. And second, in order to overcome the contamination caused by high concentration samples, we designed innovative pipes and cells. For example, under samples such as severe urea, hematuria, particle concentration with more than 5,000 per microliter, or even extremely high, such as 100,000 per microliter, from contaminating the next sample after flowing through the system is a recognized problem in the industry. Carryover contamination will directly affect the accuracy of low concentration sample results. For example, red blood cells or crystals from the previous sample are mixed in when looking for a small number of casts. So that's why solve the problem from carryover contamination is critical to greatly enhance the performance of such imaging method. And based on core products such as U3600, we provide a complete, fully automatic urine analysis solution to meet the needs of laboratories of different sizes. The flagship product, U3600 urine analysis system, it integrates physics, dry chemistry, and formed element analysis, representing the highest level of integration and automation. For U2600 urine formed component analyzer, it focuses on high precision, high throughput morphological analysis for urine formed components. And for the last one, our U1600 urine analyzer, it provides efficient and reliable urine dry chemical analysis. This page directly addresses core lab pain points in the traditional workflow. And over 30% of samples require manual microscopy, which is time-consuming and yields inconsistent results. Well, what we do with U3600, on the next slide, through intelligent image recognition plus reviewable raw images, it reduces the manual microscopy rate to under 5%. Microscopy workload is cut by over 50%, and turnaround time, TAT, is significantly shortened as well. Crucially, after automated classification, operators can instantly review high-definition morphological images for verification, ensuring accuracy while eliminating unnecessary repetitive tasks. This is truly an efficient decision support system designed for urinalysis experts. So thank you all for your patience. Urine morphology and analysis is the cornerstone of kidney disease diagnosis, and accurate and efficient cast detection is a key link. We believe that Zybio U3600, with its innovative technological breakthroughs, can effectively help clinical laboratories overcome existing challenges and improve diagnostic capabilities. I look forward to further exchanges and discussions with all of you. Thank you all.
Okay. As Ms. Zhang has highlighted application and technology of automated urine analyzer in her speech, I would like to share that we in our laboratory are using U3600 Zybio for more than a year, and we have got accreditation in our National Board of Laboratories. We have a positive experience operating it. Okay. Thank you, Ms. Zhang, for your insightful speech. We now invite all participants to engage in an open discussion. Please send your questions to the chat box. Our speakers will answer them. Join in and let's exchange ideas together. First question for Professor Ida Parvati. In the diagnosis of UTI, urine analysis has its limitation. What can we do to improve diagnostic accuracy and reduce misdiagnosis and misdiagnosis. Could you share with us how your laboratory approaches this?
Okay, thank you for the question. Well, in general, the Zybio is actually already adds on the unique parameters like microalbumin, ACR, and PCR. But for UTI screening, I think there is still a room to improve, like incorporate a new biomarker to the urinalysis, or yeah, in some studies, the development of urinary biomarker for infection is like NGAL or procalcitonin. That's for development of urinalysis for UTI screening. And could you share with us now your laboratory approach? Yeah, in my laboratory, the most important thing is the specimen collection actually, because there's a lot of contamination in the in urethra. So first, we already have regular training for specimen collection, and second, we improve our urinalysis machine when we have an affordable new technique actually, yeah, every 5 years. And the other, the communication between laboratory and clinician. If we found some different different result or inappropriate result uh, in laboratory compared to clinician. The communication with clinician is very important. I think that's what we done in my laboratory. Thank you, Dr. Sulaksmi.
Okay. Next question is to next question is to Ms. Tizin. How to explain the results inconsistency of dry chemistry, LEU, and sediment analysis, WBC?
Thank you, doctor. Thank you for your question. And sometimes you might run into a situation where you get positive result for LEU from your dry chemistry analysis, but a negative result for WBC from your formed element analysis. Well, there might be several explanations to this situation. And the first situation would be the hypotonic urine causing WBC lysis. Second would be you're testing a contaminated urine. For example, the female secretions or formaldehyde contamination. And the third situation would be it's excessively high sensitivity of your test strip, because a just calibration factor for LEU parameter will cause the similar situation. And the fourth problem would be the high bilirubin urine causing false positive dry chemistry results. And the fifth would be from some drug interference, for example, the nitrofluorescence. And vice versa, sometimes you will get negative for LEU, but a positive result for WBC. Well, this is because maybe the presence of only monocytes and/or lymphocytes in urine. Well, it does not require resolution. Explain clearly to your clinicians would be all right. And the second explanation to this situation would be the high specific gravity urine, preserving WBC integrity. So that's why you get positive for WBC. And the third explanation would be the interference from crystals, semen, or other cells, causing false positive WBC count. And the fourth explanation, I think it should be from drug interference, just like the one I mentioned before. The high concentrations of reducing substances, for example, the ascorbic acid like vitamin C or cephalexin or gentamicin, some antibiotic drugs like this. Thank you.
Okay. So today's session marked the fourth installment of our DiagHub webinar series, highlighting the evolving role of urine analysis in clinical diagnostics. We were honored to have Professor Dr. Ida Parvati from Indonesia and Ms. Sijing Leong from China sharing their expertise on the latest advancements in urinary analysis. A heartfelt thank you to both speakers for their insightful and practice-oriented presentations, and to all attendees for your active engagement and thoughtful questions. Together, we are exploring new possibilities in routine diagnostics and reaffirming the value of urine testing in modern clinical care. Thank you all.
Thank you.
Yeah.
As we come to the end of today's DAGHub session, I just want to take a moment to sincerely thank everyone who made this possible. Our wonderful speakers, our moderator, and of course, all of you who joined us from across the world. What we discussed today may center on urinalysis, a field that is often seen as a routine, but I think we were all reminded that even the most fundamental tools in diagnostics are constantly evolving and still hold so much untapped potential. Your thoughtful questions, your active engagement, and your openness to exchange ideas are what truly brought today's discussion to life. And it's this spirit of collaboration that keeps pushing DAGHub forward. We are grateful to have you on this journey with us, and we are already looking forward to the next session. So until then, stay inspired, keep exploring, and thank you once again for being part of today's conversation. So thank you, and see you next time.